So this is today's agenda. We are going to talk about the citizens' jury. I'm going to talk you through what the citizens' jury was, how it happened, and where we got to, and then Dennis will talk about the recommendations. We have one of our jurors with us today, Lynn Laidlaw, and she's going to explain to you her experience of the process. And then Dennis is going to discuss the outcomes of the conference we held about 2 weeks ago, where we presented the recommendations to a lot of people in the system. So we had a really good representation from, we had a couple of the jurors, people with lived experience, voluntary VCSE, ICB, and lots of clinicians were there, it was a really well-attended event, and I hope everybody who attended enjoyed it. And then we've got Graham Sayers talking about GIRFT, and then we'll have a little panel discussion at the end. Just to let everybody know that this is the last community of practice where Health Innovation North East North Cumbria will be hosting. We've had 2 people come along from ARC, so that'll be Dennis Martin and Cormac Ryan will be taking over the hosting of this meeting. It'll continue pretty much in the same timeline, but it will just it'll flow, and admin will still be supplied by us. So Dennis is a professor of rehabilitation and director of the Centre for Rehabilitation at Teesside University, and Cormac is professor of clinical rehabilitation at Teesside University. And Dennis, you'll be hearing from Dennis shortly. So if I can just remind you all, if you can keep your microphones off, that'll be smashing, and we'll just crack on. Thank you. So next slide, please, there, Lola. So for background and context, we know that in our region, we have high opioid prescribing rates in the Northeast. It's deep-rooted in health inequalities, and it was felt that there was a need for a citizens-led insights into pain management. So this has been moving along for about 2 or 3 years before we as a system managed to make it happen, and funding became available last year, and we started the process last November. So this has taken a year to get to this point. Next slide, please. So the purpose of a citizens' jury is to explore public perspective on persistent pain. In this case, citizens' juries can address any question, but in this case, persistent pain was the question we wanted to address. It generates actionable recommendations, but what it also does is supports the NHS duty to involve and co-produce with patients and public. And it's a relatively, we know PPIE is really important, and there's different ways people do it, but this was a really deliberative, standardized way of managing that process. Next slide, please. So the methodology, the citizens jury model comes from the Jefferson Center in America. It's been going for a couple of decades now. I'm looking at Dennis now to give me a little nod to say whether yes, that's right. So it's pretty well established, and as I've said, they look at various different questions and get the right people involved. So the right people create the oversight group, and we identified, Dennis, myself, and all of us who hosted the citizens jury, identified up to 16 members of the, I'll say system, but that was ICB, it was VCSE, it was people with lived experience, clinicians. We tried to get a really diverse group together to give insights to create the process and to understand what kind of areas we should be thinking about. So it was the oversight group who devised the question, and that was probably not until about March time, where the question it took us about 3 hours over a week to develop the question. Once we had the question, we could go out and advertise for the jurors, and it went out to advert via Indeed, the job application website, and it went off to various different it was socialised through various different groups, VCSE, communities. So we had a massive response. Over 300 people applied for this job, and 14 were appointed, and they were appointed based on what all of us were trying to do was represent the demographics of the Northeast in the jurors. So that would have been, we wanted more women than men, because more women experience persistent pain than not, and we wanted at least 30% of the jurors to experience persistent pain, because that's the makeup of our population in the Northeast, North Cumbria region. So once the jurors had been identified, they were employed, so they were paid for 35 hours of work, some of which was a learning experience where they were given the information we felt was, from speaking to the oversight group and various different experts, they were presented with the information it was felt they needed to then go into deliberation, which happened over a weekend in June. And the 14 jurors attended a face-to-face session where they worked really hard to generate the recommendations that came up. So that was through expert presentations, which are all on our website, role plays and group analysis. If we go on to the next slide. So this was the question. How do we achieve a shift away from medical intervention to better support people who live with persistent pain? And the questions above were the evolution towards that. And it was with real insights and direction from VCSE partners that we came up with that question. It wasn't, and that's why it took so long to come up with, because we really thought about what is the question we should be asking the jurors, what is it that we need to understand more. If we go on to one more slide, I don't know if I've got one more after this. So the key findings: over-reliance on opioids, inequitable access to non-pharmacological treatments, and the socioeconomic disparities were what we recognised were issues in the Northeast. Now, I think we're going to go on to Lynn's slides now, is that right? Oh, so one more after that. So in order to come up with the recommendations, each of the recommendations had to fulfil these criteria. So does that recommendation reduce the need for opioids? Does it get to the right help to the right person at the right time? Will this actually work in real life? So if it isn't going to work, there's no point even putting the energy into it. Will it work for everyone, especially those in rural areas or with fewer resources? And does it help services work better together? So they were the questions. Now, we've had a discussion in the background, and Lynn will come on to this, that this was an uncomfortable process just because it was new. It was new and we were opening it up, and I personally felt as though I was almost relinquishing control, opening up this area to a wider audience and what's going to happen. And it was almost like jumping off a precipice. We weren't quite sure what was going to happen next. And I think you'll see from the recommendations, it's been a really, really interesting process. But because it's new, I think it's worth acknowledging it's uncomfortable. It really is uncomfortable because it's new, and anything new is uncomfortable because we're still getting to grips with it. So I'm going to let Lynn come and talk about that now. Not necessarily just discomfort. So
Thanks, Victoria. Yeah, if you put it onto the next slide, please. So apologies, I have a chest infection, so I'm hoping to get through this without a massive coughing fit. So my name's Lynn Laidlaw, and thanks very much for the opportunity to speak at this event. And I was one of the jurors. And actually, I love this quote: "If you aren't at the table, then you're on the menu," by Elizabeth Warren. And I think that just sums up, why actually you should involve people. So I don't speak for the other jurors. I live with a rare disease and multiple long-term conditions, including persistent pain. And you will know I have used the language "live with," because I'm not a persistent pain patient. It doesn't define me. and I don't suffer from persistent pain, and I'm not burdened with it. I work hard to manage it and my other conditions. Next slide, please, Lola. So I'm going to start by explaining my context, my experience with persistent pain. And also, I've just put my competing interests there and I've just wanted to highlight the importance of reflexivity. So that's sensitivity to the ways in which our individual experiences and biases influence our actions and those of us around us. We talk about it a lot in qualitative research, but I think it's essential if you're going to co-produce and involve people. So I became unwell over 10 years ago, and what followed was a 4-year diagnostic odyssey before I was diagnosed with a rare autoimmune rheumatic disease in overlap with one of the inflammatory arthritis variants. And I've since gone on to develop other conditions affecting things like my heart. And one of my earliest and persisting symptoms has been pain. Indeed, I call pain my early warning system, as each condition that I have developed has started with pain. And I'm not going to go into too much detail, but on my diagnostic odyssey, I had over 10 second opinions across the UK. And it was challenging to navigate the system, which was built on single organ conditions and not holistic care. And it felt like collecting pieces of the jigsaw, which were put together to reveal my diagnosis. There was a lack of clinical curiosity because actually I don't think the system allows it. And I had to drive the process with the assistance of my excellent GP. And I was fortunate. I'm articulate, I'm health literate, I have a supportive family, and I had the resources to travel and pay for second opinions. And I was referred to a pain clinic where I was told that they weren't interested in the cause of my pain. And I think because I was a woman of a certain age, I was told that my symptoms were significantly psychological. But I always believed that the answer to my pain was to find the underlying diagnosis. And that was a means to an end. And it was a really challenging experience. And I had to ask myself, was I so arrogant that I thought that I knew better than all these really clever people that I was seeing? And eventually I had the right tests that were interpreted by the right person, and I got my diagnosis and evidence-based treatment, biologic drugs, which, while they're not a cure, have made a real difference to the quality of my life. And I had to come to terms with my experience and the impact of not being believed. I didn't feel that I was believed. And I was fortunate to access the services of a clinical psychologist through my work. And I was forced to take ill health retirement age 50, but since then have become an experienced patient and public contributor research and also a peer researcher. Next slide, please, Lola. And I've put this up because I feel this quote from Margot McCaffrey remains relevant today. So what attracted me to apply for the citizens' jury? Well, I felt I had skills and experience and expertise that could be useful to the process, but I was also really wary because I knew that there would be a huge amount of emotional work involved. And my experience of being involved in persistent pain research weren't positive. And I haven't done any actually for a while, because actually researchers didn't want to hear experiences like mine. And as part of the process, I met with Anna from All of Us, and I was asked if I had any strong opinions on the treatment of persistent pain. Well, of course I did, as pain is personal. But I knew that I would need to be particularly reflexive throughout this process. Next slide, please. So I was notified that I had a place, and I started the homework preparation that I'd been sent in advance. And as I watched the evidence videos that we'd been seeing, it struck me right away that the language was very technical and exclusive, not inclusive. And the people presenting their evidence used terms such as neuroplasticity and biopsychosocial. And unfortunately, that meant that time in the breakout rooms on the jury, where we should have been discussing the questions we wanted to ask, were spent on asking for definition of technical terms. And actually, you know, when they were setting up the jury, they'd worked with a health literacy specialist, and it was a shame that that didn't carry over into the jury presentations. And also, there wasn't any, you know, no one presented their competing interests, and I felt that was important, because people were appearing on screen beside their app or their toolkit or their book, and this aspect made me feel really uncomfortable. And unfortunately, my time in the jury coincided with a painful flare of my inflammatory arthritis. And I went to see my GP, who encouraged me to take pain relief, which I don't really do and I don't like to do. But actually, taking the analgesia was needed, and it allowed my symptoms to settle, and then for me to get back to the things that I do to manage my pain, which is actually exercise. So it was a timely reminder of the dangers of fixed thinking, which we all fall into, and the need to adapt to situations regarding pain management. And the jury question, how do we achieve a shift away from medical intervention, was, I felt, a bit opaque, and medical intervention wasn't defined, but it became clear that it meant opioids. And it was suggested to the jurors that if patients were offered opioids for their pain, they should refuse them. And I thought about the things that I had found written in my clinic letters and medical notes when I had refused what I knew to be inappropriate medication, including opioids, namely that I was non-compliant and had refused treatment. And of course, we don't write notes from patients' point of view. Data is captured about us, and clinicians decide what aspects of consultations to record. And my notes and clinical letters failed to capture or highlight what was important to me. And we heard a lot in the evidence sessions about the need for self-management. And I'm great at self-management because I have the access to resources to do so. And this slide, I've showed this slide because I think it's fab, and it reminds us that choice is a privilege. And it's much easier, isn't it, to talk about individual behaviour change and put responsibility on the individual. And I came across a great paper recently that described this as the lazy language of lifestyle, because there's two types of behaviour change, individual and systemic. And I think when we frame it as an individual responsibility, we can obscure the systemic causes and divert attention and investment away from the structural reforms that create healthier and fairer societies. Next slide, please. So I've included this slide because it was from a qualitative evidence synthesis that I was involved in co-producing, where we looked at the work of living with multiple long-term conditions. So this work is poorly recognised and not captured in routine data. And I'm showing this because we know that many people living with persistent pain will live with multiple long-term conditions. And indeed, as part of this research, we found that persistent pain made all of this work so much harder. And I think this is an important issue to consider when we expect people to take on even more self-management. So the early jury sessions were online, and halfway through the process, a mixture of pain, discomfort with some of the evidence presented, and just the emotional work of being reminded about some challenging past experiences had me question whether I wanted to continue to be involved, but I'm glad that I did. And the last 2 days of the jury were face-to-face, and what a difference that made to meet my fellow jurors, and the people they'd been facilitating the process made such a difference. To talk to people, to pick up on the non-verbal clues, share a cup of tea and some biscuits, and debate the issues in person felt great. We built trust in each other, and crucially, I started to trust the process, which I don't think I had up until that point. And as Victoria said, we used various methods, including role-playing, group work, to start making our recommendations. And it was a timely reminder of the value of human connections. And we were able to do things like take a deeper dive into the evidence base, so like, behind communication campaigns and whatever. And also, I think one of the best recommendations was this taking the eye out of pain to remind people that they are not alone. And if I was to analyse the themes of our recommendations, then they reflect the following: the need for better education of staff and patients, the importance of understanding each individual's context and tailoring services to their needs, the power of community, and the need to recognise that pain is a long-term condition that people need to manage, as I said, often alongside multiple other long-term conditions, but also the need for a really strong evidence base to guide treatment, because arguably for too long, people living with persistent pain have been subjected to medical treatment that has caused harm, and the least we can do is not perpetuate the problem. Next slide, please. So I want to finish with a few provocations. When I read the report of the jury and the recommendations, it talked a lot about co-production, and I love these images from my favourite paper on co-production by Sarah Knowles and co-authors. So how many times do we hear about patients being put at the centre? And I wonder, what agency and autonomy do people do when they're put somewhere by others? And often involvement, next slide, please, Lola. And often involvement in co-production is seen as a box-ticking exercise, but in reality, they require time and resources, and they're driven by shared values and principles. And we need to recognise this as a state of being, the values and principles that we inhabit, not just doing, as in Lynn, tell me how to do PPIE. But we also need to embrace the productive tensions and make time and space for conversations which should lead to genuine change. Next, please. And, I think that citizens' juries have been termed deliberative democracy, but I wonder if they're a form of performative democracy, if there isn't co-production and involvement throughout the whole cycle, particularly when it comes to setting up new services and changing existing ones. What needs to change in the culture of service change and provision to make this a reality? And I was glad when Susan encouraged us to make a recommendation regarding this. And it was interesting at the event a couple of weeks ago that Victoria talked about, that people talked, the people there talked about finding the right person to share their stories when they were presenting about persistent pain. And it made me wonder, are there some stories that are too challenging? And what control do people have about how their stories are used? I'm choosing to share my story today, but I'm in control of that. And I have picked out, I can't control how you perceive it, but I'm saying the things that I want to say. So next slide. So this is my final slide, and it's a perfect illustration of services as imagined versus services as actually experienced. And involving the public in service provision and planning doesn't detract from the skills and experiences of anyone else in this virtual room. It adds to the process. And I understand that your services or your research can seem like your baby. And sometimes people let me rock up and tell you that their baby
I think you deserve a bottle of wine.
No one will care about service position for and research into persistent pain more than the people living with persistent pain. For us, services and research signify hope. And if we didn't think we could help, we wouldn't waste your time.
Thank you, Lynn. I think if we go on to the next slide there, Lola, and I will just thank Lynn. Lynn, you make some really good points there. I think it's worth recognising this process is in its infancy, and we are going to get it wrong before we get it right. And we need direction, and we need that backwards and forwards discussion to understand how to do it better. And I think sometimes that's uncomfortable, and I think we just need to recognise that and move on with that in mind. But with that in mind, let's bring in Dennis. Now, Dennis is going to give you a taster of what the new host is going to look like and sound like. So let me introduce you to Dennis. So on the back of the recommendations, we had the event 2 weeks ago and we got your feedback, and Dennis is going to feedback that there. Dennis, I'll hand over to you.
Thanks, Vicky. Yes, what I'm going to present here, I'm going to run you through the 6 recommendations from the jury, and then give you some insight into some of the issues that were raised and debated and put out at the stakeholder event that we held in Gateshead a few weeks ago. Now, at that event, that was attended by up to 100 people from the full spectrum of stakeholders in the region and a little bit beyond. What people were asked to do, and you'll see this coming up in the slides, people were presented with the recommendations and then asked to debate them, and then put notes up on the board about what would success look like in terms of trying to achieve the recommendations. What are examples of good practice in the region or beyond, and who are the key people or bodies or agencies of influence and change that could link up with the recommendations to put them into practice. So what you're going to see are the recommendations and then some of the feedback that we got from the event. That's still being analysed, but some really, really interesting points. First of the 6 recommendations was that there should be a social marketing campaign, a public campaign, and there was a specific guide, this idea of taking the I out of pain to say that you're not alone. The graph here shows the level of support within the jury members for this recommendation. And the green and the blue, both of those are showing that this was strongly supported. Next slide, please. Yeah. So when we presented this to the group in Gateshead, we took the ideas that came from the group and sort of tried to work them into themes. And as I say, that's still ongoing. The key points from this, now one, the stakeholders, in terms of that quite prescriptive guide about what a campaign should be, take the I out of pain because you're not alone. There was a consensus that liked that context of emphasizing you're not alone. What was interesting, they thought that specific thing, taking the I out and what it would look like after that, could lead to conflicting and confusion, and conflict and confusion within the messaging. And it was very important from that group that what a campaign should be clear about, there should be clear and consistent messages within that campaign, and that the messages should be consistent for people with pain, members of the public in general, and healthcare professionals and the wider stakeholder group. It threw up an interesting phrase, one I thought was interesting, which comes up a few times, that the action for this recommendation, the campaign, the public health awareness or whatever, should be culturally competent. And that taps in very much to ideas of health literacy. That's really, really important. And also there was a lot of discussion that as well as raising awareness and understanding, there should be clear links allied to action, things that people can do, things that people can find out about. So not just raising awareness, but emphasis on what can be done. So there's some really good examples of good high-level activity. And what's interesting with this one was there was a lot of highlight of actions which are already happening, which have their roots in the region, but actually extend out nationally. I'm really coy about giving specific mention to things here. It's a bit like if I was ever to win an award for anything and I had to thank those who were involved. I would hate to do so because I would probably forget some important people. So if I do mention some, and some that you know and are linked with and don't get a mention, that's pure omission on my part. But having said that, there are examples. For example, Flippin' Pain is seen as a flagship for a public health campaign, and Living Well with Pain is another one based in the region which expands out. Those sort of initiatives. That throws up a really important point of synergy, that for the recommendations to be actionable, you don't have to start from scratch. There's plenty of opportunity to get good practice and build on that. Include these some of these ideas in, or build on them and spread that activity where it's happening. One of the things I think didn't come out clear from the feedback was the importance here of this recommendation of the social marketing aspect of it, the targeting the message to the specific segments of the population related to their needs. That was something that different in the recommendation, which was quite clear. There was some good information that came back from the group of initiatives, not pain related, but ones where perhaps that was happening and we could learn from that. Next slide, please. Recommendation 2 was that training should be mandatory. Training in pain management of persistent pain should be mandatory in universities and at CPD level. This was strongly supported by the jury, and the feedback coming from the Gateshead event was a big tick for yes, mandatory is important, and mandatory, that edict is probably best placed to be coming from the accrediting bodies, the bodies that accredit the courses in the university. And is that directed to me? I'll take it on board if it is. At universities and in practice training. A couple of really good points came up about yes to the emphasis on the biopsychosocial approach, and that should be seen as a very positive alternative to an exclusive reliance on medication. So to emphasize the positive aspects of that, and also to warn against taking it as a sort of a general term, biopsychosocial, but to clearly get across the understanding of what is the bio value, what is the psycho value, what is the social value, and how does that all mix together. So to get it from an airy concept, which sometimes it is, and that's open to interpretation, to really dig into what is it, what are the key theories. For example, pain neuroscience education is a good example of that. And also very, very strongly, not to sit and be comfortable on teaching the theory and teaching the sort of the technicalities, but actually putting it into practice, getting this into practice in real life situations. Interdisciplinarity, multidisciplinarity was strongly emphasized from the group, with a real big support that there should be a very strong and clear space for the voice of people living with pain to be part of this, and that should be incorporated fully within the whole range of disciplines. Some very, very strong examples of good practice in the region again, and actually with a relatively limited stakeholder list involved in this. I think there's opportunities here for a clear regional initiative to get people together, share what they're doing, and actually look to implement things across the region. And one of the things that was coming across very strongly was it would really help get over some of the barriers to implementation within courses of, well, what are you going to take out? Where does this go? And what does it replace? Pain education. If pain, persistent pain, was seen as a long-term condition in its own right. Next slide, please. Next slide, please. I've covered those. Next slide, please, Lola. Lola, can I have the next slide, please?
Lola, can you hear us? Or is Lola frozen? There we go.
Yep, that's it. That's it. Yeah. No, next one. Next one is about the idea was there should be multidisciplinary hubs which meet local needs. And
next slide, Lola.
This is timely, actually. Hopefully by this time there's been an announcement about the proposed neighbourhood hubs in the budget, and there was strong support for this. This idea of multidisciplinary hubs in local areas of need was very, this one was really pushed by the jury, and it was seen as a way of decreasing barriers to integration. The idea came up again that this was an opportunity for meeting local needs with locally relevant services and support, and the idea of cultural competence came up again, linked very closely to health literacy. There was a strong emphasis here on the needs of rural communities for various reasons, and one proposed solution was looking at mobile services, so taking the service into the rural communities. There was clear discussion about the space for digital technology as an enabler of this. Another important point that was raised was the role of social prescribing and link workers within such a space. And again, here we saw some examples of really good practice already. Ways to Wellness is one springs to mind, and then which taps into this idea of building on success, scaling that up, implementing it, and spreading it. And the idea of synergy, I think, is a strong one here. If and when neighbourhood health hubs or something like that idea becomes mainstream, then I think this is an example of it would not be necessary to have specific pain things set up, but perhaps what we're looking at here is making sure that the content within these, that there's space here for information, guidance, and support around pain. That idea of synergy was strong in this one. Next slide, please. Now, recommendation 4 was one where pain, persistent pain, should be considered as a long-term health condition in its own right. This received strong support, and the feedback from the stakeholder event was also very strong in this. There was a lot of value. Next slide, please, Lola. Sorry. There was a lot of value seen in this one on a number of levels. Value for people living with pain, helping to legitimize what they were experiencing and reduce stigma at times for some people. Value at a national level, where if and when pain was officially recognised as a long-term condition, it opens up opportunities in the COF process and enabling clear and formal coding of the condition, which could help at that level. Regionally, I think there was value in that where there's good, strong regional strategies on managing long-term conditions and managing multiple long-term conditions. This would be an opportunity to provide all that value for people living with pain and for services set up for people living with pain. An example of that was the strategy on multiple long-term conditions from the ICB, which actually, when I read through it and saw some of the presentations on it, to me, this was everything written with relevance to pain, persistent pain, apart from the fact that persistent pain never got a mention. And it's an interesting one, that there were lots of examples of really good regional initiatives which are set up, pathways and services for people living with persistent pain. And these were operating on an unsaid basis, if you like, that persistent pain is a long-term condition in its own right. It's that sort of saying, if it looks like a duck and if it walks like a duck, well, it is a duck. And persistent pain does look like a long-term condition and it walks like a long-term condition. It is a long-term condition. And it's interesting to look at the history of models of long-term condition management, and a lot of them, if not all of them, are actually pioneered by developments in management of persistent pain. Now, it's easy to say when you're looking at who's going to make the change, it's always easy to say everything should be the ICB. The ICB should do this, the ICB should do that, the ICB should do everything. Probably not, and it doesn't have to apply across these, but actually I think this is one where the ICB could take the bull by the horns and really start to push this idea that pain is a long-term condition. That would be helpful within the region. I think it's within the gift of the ICB, and it would be a good impetus to start lobbying at national level. We did this in Scotland with success. No reason why it couldn't happen again. Next slide, please. This slide was to really keep the jurors involved in the process and keep the jurors involved in trying to get implementation and action on the recommendations. Next slide, please, Lola. the feedback from the Gateshead event agreed with that, and also considered the recommendation within the wider area of involving people with persistent pain in policy making and in practice and in all that process. And the feedback from the Gateshead event, there was very, very clear acceptance of the importance and the value of that, and that such involvement should be authentic and not tokenistic. That was clear. There was discussions trying to identify the clear mechanisms in various aspects of different processes, how that could be done, and talking about how it can and should be done formally, to the extent of having official roles for people and providing payment to recognise that. There were some issues brought up about problems and looking for solutions without without over-reliance on and being overly influenced by individual experiences, trying to make sure that that input was more of a degree of being representative, and there was a recognition that processes like the citizens' jury were ways of doing that. Not an easy answer, but an important issue about very important, but the representation aspect of it needs to be there. Next slide, please. Interesting final recommendation was that there should be establishment of an independent national pain institute. This one received strong support, and this came from one or two of the expert witnesses who were pushing this point. And it's an interesting one to see. What came back from the Gateshead meeting was lots and lots of questions about this. Next slide, please, Lola. Why? What's the purpose of it? What's the function of it? Is this not already happening? Is the Pain Society not doing this? What about the North British Pain Association? Is that not happening there already? But I think what was coming across was a distinction between those sort of professional groups, interest groups, as opposed to what a specific idea of an institute would be, of really focusing and concerting and concentrating effort at a large scale and with a large degree of power to deal with big issues, with powerful projects. The UK, the government funding bodies and Versus Arthritis actually did get together to provide funding for something like this, to try and sort of drive things at scale. Now, my understanding is that those projects are ending very, very soon, and there's nothing in place to carry them on. And I think that's where the push for a national pain institute is coming from, to have a sustainable collaboration, to allow this concentration of effort and big action to take place. Interesting, within the region, the Northern Health Science Alliance has set up, or is in the process of setting up, a virtual institute for preventative health research. And that's something that's perhaps, going back to the idea of recognizing pain as a long-term condition, could fit in with that initiative a possibility. Next slide, please. So lots of implications for policy and practice. And I think you can see that the recommendations tap in to current discussions and initiatives. Nothing foreign here, which helps with the idea of synergy and building on good practice. And the jury process itself offers a model which can be replicated for public involvement. I think the key themes, just to finish off, key sort of themes were that it's clear that there are often multiple stakeholders in relation to all of these recommendations. And I think really all have to be involved to try and implement them. There's perhaps something to look at the value of getting top-down support and validation of some of these bottom-up initiatives which are already there, and bringing that support clearly in line with what's happening in practice and spreading that out. Real good opportunities for synergy with existing areas of good practice, real recognition of the value of the experience of people who live with pain, and this idea of initiatives being culturally competent and paying due respect to health literacy and making the most of that is coming across. And what we want to do is take these recommendations, push them out there as we're doing today, as we did in Gateshead, and push them out to agencies of change and influence, including, and Graham, our next speaker, will talk about this, GIRFT at a national level. Thank you.
Thanks there. So, thank you. Thanks, Dennis. So we've got impact and next steps. We've had the meeting where we shared the recommendations out to the wider audience. We're now discussing them again today, and now let me pass you on to Graham Sayers, who is going to discuss GIRFT. Thank you.
Thanks, Vicky. Thank you, Dennis. Really thought-provoking, Dennis. I could listen to you for another half hour on that, and it would take me down all manner of different avenues with my thinking. I think that your ideas about neighbourhood health and how that might fit with some of the levers for change would be worth exploring. I'm cold. I'm in a room. I took my laptop on a walk. I don't know if you noticed, because I was in a really noisy room, open office, and I couldn't hear myself think. So now I'm in a quiet room, but it's cold in here. So I'm Graham Sayers. I am a GP in Northumberland in Alnwick, and I am a clinical lead with the ICB, a place-based clinical lead though really, so Northumberland and North Tyneside are my patch, but I have also worked more widely around the Northeast on the agendas around pain. There's a clinical pain network which we formed. I've been involved in a lot of the prescribing and the de-prescribing, taking on board what Lynn said. Pain isn't all about prescribing though, at all. And we learned that fairly quickly. And that's where this idea about a more biopsychosocial approach came from, really. Next slide, please. So GIRFT is not the answer to everything that's wrong with chronic pain. Let's be very clear from the start. Get it right first time. GIRFT is an organisation which is a subgroup, if you like, of NHS England. So I imagine that to be London based, but actually these days everybody lives all over the country that's involved in NHS England type things, as far as I can tell. And it started initially looking at variation, and it is led by Professor Briggs, who's an orthopaedic surgeon, and one can imagine early on, pre-COVID, looking at the variation of activity at procedures of perhaps variable benefit. So arthroscopy in somebody aged over the age of 60, one could argue, is a procedure which was a variable benefit, and the GIRFT system allowed data to be seen to look at variation across acute trusts about places where variation was occurring, perhaps waiting lists were longer, and visits occurred, looking at the data to those that appeared to be outliers, both with high activity and low activity, and then change came about because of that. And that would be the very first principle of GIRFT, I guess, is looking at variation and understanding it. And pain has been considered now as something that would be worth looking at. But pain is very much a system issue rather than perhaps an acute trust issue. Next slide, please. I have been appointed as one of the clinical advisors within this GIRFT stream on pain. Helen Makins is an anaesthetist, specialist in pain management in Gloucestershire. Jackie Clinch is a rheumatologist in children in Bath. And this pain review is actually looking at chronic pain across the life course. So children who suffer from chronic pain, it's quite a specialised field, and there's a huge variation in the services available to them across the nation. We will be looking at both interventions in pain clinics, but also looking at what's provided in the community and what's in primary care as well. So it's across the breadth of pain. It's not just musculoskeletal pain, and it's not just about all of those things that happen in hospitals. It's community services too. Next slide, please. It's multi-agency, so it's not just some clinicians looking at this. We do have an expert reference group, and we're working as closely as we can with everybody else that feels they're in the field. The citizens' jury work just happened to be occurring at around the same time, and the British Pain Society are involved in that. So it's trying to link everything up, which comes back to what Dennis was talking about, influences of change, and it being multiple agencies that can bring this. Next slide, please. In the centre of that slide is the chronic pain work stream, but you can see within GIRFT, it's part of the musculoskeletal improvement programme. In the Northeast, we've recently seen the spinal work stream. So Dermot Ferguson is a GIRFT local participant, and they've been looking at spinal issues, and that's led to some of the changes in intermediate services about a single point of access for spine. So there is lots going on. There is a community MSK work stream which looks at intermediate services for MSK and access to physiotherapy and MSK in that side, but pain is just part of that work stream. Next slide, please. This is a graph which just illustrates that at a strategic level, so this is the amount of opioids being prescribed in different areas of our region. So the top dark brown one is Tees Valley, the lower grey one is Northumberland, and the dotted line is the national average. So one can see in the Northeast at a strategic level, we have variation, and over time it's changed. GIRFT looks at variation, but you could equally put up a chart that shows how many people are being seen in acute pain clinics in the different acute trusts in our area. Or you could put up what are the waiting times in acute trusts. You could put up how many people are seen in community services for chronic pain in our area. But then that brings us back to the thing about, is pain a long-term condition, and is it correctly coded just like diabetes would be? And can we spot variation as easily and track what happens to the people who suffer from pain in a reliable way? And actually, we've discovered in the early part of the GIRFT work, it's difficult. The databases are difficult to take interpretation from. Next slide, please. This shows what local go back one. What local variation data might help you with those. So there's a blue line on there, which was one practice, was identified as varying, and a specific intervention was put in place in that practice to try and support people who may wish to try to reduce the number of opioids that they were being prescribed. And one can see if you identify variance and you have something that helps that practice, that practitioner, that service, doesn't really matter what it is, but an intervention you can then help them change. And that practice then was able to track its change. On the whole, you can also see that actually in the Northeast, opioid prescribing is generally gradually reducing. And that's going to be a good thing for many reasons. But on the other hand, we have to get away from the rhetoric that all medication prescribing is bad. So that's just taking on board what Lynn was saying early. Some people will need to have medication at some point, but it needs to be done as part of a holistic approach and not just a reflex prescription that was made without taking on board everything else that's happening with somebody. Next slide, please. So just some general principles of GIRFT. It is a collaborative exercise. It shouldn't be top down. It's about trying to involve everybody in the system as effectively as we can. We do have access to data. We have an organization called EDGE who are commissioned to try and find data, crunch data, present data. So we hopefully will be able to identify variation as accurately as possible. Getting back to it though, it's not about changing the end point from the end. It's about preventative treatments, early interventions, finding out what works early on. So that's very much a long-term condition approach if you think about it. And it's about reducing variation. Next slide. What steps? How is it actually happening? So there are these reviews going on of services, which lead to the visits, which I'll come to in a minute. We do have an expert reference group. It met this morning. We had a webinar last week, and actually a number of people who watched on the webinar came forward and said, oh, we don't think you've got any OTs involved here. So now we have the Royal College of OTs on the expert reference group. So it's all about discourse and change as we go along. What we do with the expert reference group is describe what we're trying to do, how we're trying to get there, and take ideas from them and try and modify what we're doing. So it's done in collaboration all the way. There is a questionnaire survey which has been designed, and when we identify places which will be invited to take part in the visits, which won't be everywhere in the country, but it is a system visit, so it's based around an ICB patch, because we want to know what's going on in primary care and communities, not just what an acute service is providing, acute hospital service. The visits, and we did a pilot site visit last week, and lots of people need to say lots of things, and it's quite difficult on a call to get everything from everybody, and it's important to set up the expectations beforehand. We get the data, we get the answers back from the questionnaire surveys, which should be going out to all bits of the system beforehand, and then we think about what our lines of inquiry might need to be based on what we can see from the questionnaire and the data. What we are finding is that because this is a system thing, the ICBs need to be quite key to holding the ring on where the different services are in the communities. And in large areas like the Northeast, we've got a multitude of different historical commissioning arrangements for different services. And I think it's not very well joined up. And it's really hard to have that idea about who is leading this kind of approach across the whole patch, so that if we want to do it a bit differently through neighbourhoods, how do we make sure the levers allow us to do that? I've mentioned the webinars. Oh, just back on the visits, the Northeast North Cumbria will be having a visit. The date is set, I think, for early March. And providers, I was on a call last week, some of them have already been sent a bit of notification that it's happening, but we're only as good at sending information to the people who are on national databases, and we've already discovered that some people aren't visible at a national level that have. So I was thinking about Dennis. Dennis probably hasn't had an email. Should he have an email about the questionnaire about what education is going on around the Northeast or the research around it? Probably should, but not sure if he's had an email. And it's up to the system to circulate to people that know that people might be interested. Community of practice will be developed hopefully as things go forward. This is a community of practice. We're talking about a more national community of practice, which might be a place to do bigger picture educational stuff, but might also be a place to do some of the other recommendations that the citizens jury is coming up with. Don't know, but I think it's all in flux. Next slide, please. What will be the outputs of GIRFT? All those things, but hopefully lots of dialogue, lots of change. I don't think GIRF will suddenly say, and you must spend an extra 60 million on pain. Don't think that's the kind of recommendation GIRF can come up with, but we can write a report that might help push national policy towards long-term condition, coding, education, all of those things. But actually, I think it also is going to create some friction in systems, because when you start having a look at a system and you get dialogue, people will potentially feel threatened, hopefully feel a bit more optimistic, hopefully get some aspiration from it, but I think all of those things will come into it. Next slide, please. That's my last slide when I need to say anything. And really the thing that I focused on at the bottom of all of that kind of blurb was improving the patient experience. And that's where the citizens jury is key, because that's the closest we've got so far to a very recent piece of work looking at how people feel, understand, want to influence from people who are actually living with chronic pain. Next slide, please. Yeah, that's me done. Thank you. Thanks, Vicky.
Thanks, Graham. That was great. So we're going to do a little bit of audience participation. So we've asked regularly, of those 6 recommendations, which do you feel should be prioritised? So we've asked several times. We're going to ask our audience now. Lola, can you do the next slide, and we'll have a look at the Slido. And can you all have a look at this Slido? The link will be going into the chat as well. Can you just rank those the recommendations there, either via your phone with the QR code or via the link in the chat, and let's just see how you feel about the recommendations, which ones you feel are the most important, and let's just see if technology is on our side. I recognise some of the names from our meeting a few weeks ago, so you may feel as though you've already voted, and we will be seeing what the votes that came up. A few minutes to got 26 on the call. I'd like to think at least 50%. So if we go for 13 to 15 responses. I have 14, 15 responses.
Takes a bit of thinking about, Vicky.
It really does. I'm happy with that. Lovely. So we're looking at mandatory training is the first one here. Establish local hubs and recognise persistent pain as a long-term health condition. Oh, yep. I think they're pretty stable at that level. And then we've got the social marketing, then ensure commissioners work with people with lived experience, and then 6 is create that independent pain institute. Smashing. Thank you. Thank you. If we go on to the next slide there. So these were the results from the meeting 2 weeks ago when we asked the audience of about 93 people. So there's a bit of a change around, but all the same 3 are at the top. So it was recognise persistent pain as a long-term health condition came top. Establish local hubs and mobile services to improve access to support and introduce mandatory training on pain management. So they, thanks Cormac. So they are, you know, they seem to be the top three recommendations that people feel should be prioritized. So let's just open it up. If we go on to the next slide, and we'll see where we're up to right. So we'll do the evaluation at the end. So if we open it up, is there any questions? I know Dennis, we've got this information now.
Yeah.
Is there any is there anything that strikes you as particularly important? Are you surprised by the change of the priorities with this audience as opposed to another? Or do you think we need to take a more generalist view of those priorities, that they all or several of them need to happen to get the culture change, to get everything moving along? I just wondered if you've got any thoughts.
I think they all have their value, and I think those top three are consistent in both events. Isn't that right? Yeah, I think they are. I think the Independent Pain Institute, that idea, I think that I'm not surprised that one's at the bottom. It does look a bit abstract, perhaps compared to some of the other ones, and I think it needs a bit more thinking out and a bit more explaining. From what I know of it and what I know of some of the ideas behind the scenes to try and develop something like that, I think that could be really, really powerful. But yeah, I think they're all relevant. I've got my own thoughts on which I would concentrate on, but I think to just concentrate on one and drop some of the others, I think that's where the mistake would be.
Yeah, yeah. Thanks, Dennis. Thank you. Graham, your hand's up.
Thanks. So my feeling on this was interesting in that I didn't rank ensuring the commissioners to work with people with lived experience in the top three. And I felt guilty for not putting it in the top three because I think it's very important. But in terms of the question which will have the greatest impact, I felt putting some of the others at the top will move things in the direction with greatest impact. And then you would make sure that when you've made your case for change and resource and long-term condition, and you can put the resources in place to allow some significant change to occur, if that's what's required, using that people with lived experience at that point. But that's because I'm a healthcare professional and that's the world I live in. And I may be wrong. Okay. And therefore, you know, Lynn's put her hand up because she'll have some thoughts on that as well. But I think that's the culture of the way that we work. And Dennis's point at the beginning of this was, how do we change culture? And that's something to do with educating people at the beginning that the culture needs to change, or you do it. Don't know. There we go.
Yeah.
That's my.
Yeah. No. Thank you for your honesty, Graham. I think that's what we need. Lynn, your hand's up.
Yeah. So culture eats strategy for breakfast, doesn't it? And I don't think we have a culture of meaningfully involving people, public partners, in service provision and service change. And I can say that as a really experienced public partner who's very involved in research that I've never had the opportunity. You know, I mean, the citizens' jury was the first chance I had. I'm involved in a lot of research that then goes on to influence practice. I'm involved with the NIHR policy units and a lot of work with the Academy of Medical Sciences, actually working with government to influence policy. But I don't get the opportunity. And I think what really stood out to me at that event was that somehow PPI was inviting someone along to share their lived experience. It's not. It's working together as teams and understanding that there's not a hierarchy of knowledge, and that actually if we get everyone involved and not just after the big decisions have been made, and that's not easy, and it requires training, because it not only requires training for people like me, it requires training for the people that involve them. And I think there's a fundamental, because involvement in co-production strikes at the heart of our identity, and that's really uncomfortable. And I'm not, I've got more than enough work. I'm not touting for business here, but I think there's something fundamental here.
You bring up a really good point there, Lynn, that we're not there yet with PPIE, and we aren't. It's in its infancy. I think we've got some really, really good organisations who are working in that area, and I've gone and listened to talks by Shauna, who and we are attempting that process now. And as I remember being my background's physio, and I can remember being a really useless physio when I was in my early days. I'm much better now because I practiced it, and I think it's something we need to practice more in that area. So my children keep telling me that there's something called the power of yet. We're not there yet, but we should never actually get there, because we should always be trying to improve. And I think this is the start of the journey. Let's hope. So we've got more hands. Let me see. Now, all I can see is, I don't want to. Alistair, your hand's gone up. Do you want to take yourself off mute and let's see your face and ask your question?
Thank you very much. You're welcome to the deep joy that is my face. I'm just wondering if Dennis wanted to respond directly to Lynn's comment, because I was going to make another comment. I'm not sure. Dennis, did you want to respond directly to Lynn? Because I'm thinking if I do my bit, it kind of interferes with that dialogue. I'm happy to wait for you if that's the case.
Yeah. Do you want me to read that out, Dennis, so everybody knows? So Lynn has asked Dennis, I know you were reporting on what people said at the event. It's not generalizability either. Public partners should be working as part of the team. They aren't there to share their story, to represent public voice. And I think this is better understood in research PPI. And then Dennis, do you want to respond?
I agree fully with what Lynn's saying, and what I was going to say is it goes back to the point of examples of some very, very good practice within the region. The ARC, for example, the local ARC has got a work stream or a unit, or whatever you would like to call it, a very, very strong focus on involving people who are living with conditions or using the services, and have really good resources for how to operationalize that in a meaningful way. And where I say meaningful is tapping into what Lynn's saying and agreeing with that. There are really, really good initiatives to try and do that. It's not always the case, and there are easy examples of that sort of involvement being done tokenistically, and that's just ticking a box. It doesn't add value. It doesn't help with the process at all, and it's probably harmful, if you like, to the people who are participating in it. There's plenty of good steer, plenty of good activity to build on, to improve things and really get that important value into implementing the recommendations and on a wider basis. So yeah.
Alistair, do you want to come in there?
Yeah, thanks very much, Victoria. Super activity, really nice, interesting to see the outcomes of it. Sorry, my name is Alistair McSween. I'm a principal lecturer, Teesside University. I work very closely with Dennis and Cormac. Not to criticise at all the process or the questions or the recommendations, absolutely excellent. Just an observation, suggestion for the future regarding point number 3, mandatory training for newly qualified health professionals. I think it's worth considering the timescale that would take to feed through into real meaningful change for patients, because the services tend to be led and directed by more senior people, and the new health professions, that'll take time to feed forward. And just a suggestion of extending that a little bit, or for future reference, to training on pain management for all health professionals in practice who deal with patients with persistent pain as a continued professional development. But again, may I please stress not to criticise at all the work that's been done and the questions that were asked and the topic that was done. Just coming to it, seeing it now, that's just something I would think maybe for the future, or in terms of timescale of impact.
Yeah, can I pick up on that point?
Yeah,
Vicky,
and do you want us to go back to the main slide, to that recommendation?
Yeah, you're right, Alistair. That there was good discussion about that. That sentence is shorthand for the full recommendation, which covers training at CPD level as well. There were some really interesting points brought up in Gateshead about the need for that, about continuous professional development, and making sure that the undergraduate training doesn't get lost in sort of real world application, and also where people are coming in from different areas who perhaps have different undergraduate education, to make sure that there's that level of understanding of theory and practice coming in. So yes, absolutely right. And not only sort of recognizable healthcare professionals, but stakeholders in the wider, the whole wide context needs to be addressed, because the workplace is continually replacing it. Our workforce is replacing itself continuously, and you need to keep up on that. So your point is very well made, and but the Slido showing it in shorthand, the full recommendation covers that.
Thanks, Dennis. I should have maybe said at the beginning, Victoria, I work with Cormac and Dennis, and they frequently point out my errors in private. So Dennis, thank you, Dennis, for not flagging the fact. Well, I missed it on slide. I could have picked it up on. It's there on slide 2, and I apologise for missing it. But I think good point. Two-pronged approach. You know, change from the bottom and the top and the middle at the same time. Well, 3-pronged, and then results quicker. But super piece of work. Thank you.
Yeah, thank you, Alistair. So Lynn has asked the question, does mandatory training change culture? Discuss. Not in isolation, I would say, but that is just me as a therapist, and who has worked in the NHS for a long time and has done an awful lot of mandatory training. It brings it to the forefront of your mind what you need to do. So there's lots of things come through, and I think, I don't know if Dennis or Graham want to come in on this one, but I don't think one single approach changes culture. It's multiple pronged approaches, which what Dennis has said. Graham, do you want to come in?
I was happy to leave that question hanging as a rhetorical question, really, but because I think you can argue it anywhere you like. But I agree. If the culture was such that everybody perceived the need to do it, we've got the change in culture that we need, and then it doesn't need to be mandatory. And I think that's probably a note to end on, almost, looking at the time. But
no, absolutely. No, we can end there. Lola, if we put the last slides up for quick evaluation, tell us how we've done. According to me, I've only got 21 left in the room. Good. So we'll just pop the polls up. Tell us how we've done today. It's the last one for us. So how would you rate the overall meeting? If you could just let us know how you felt it went. Then what did you find was beneficial? and what we could improve on. Just so we can send some responses over to Dennis and Cormac and let them know this is where we got to. I'm handing the reins over to you. So as you're filling that in, thank you. Let me just come on to thank everybody. Thank you to the speakers. Thank you to Lynn. It's I think sometimes it can be quite daunting speaking to an audience. Yeah. And I think you handled it very well, and we do appreciate your insights. We really do. It has to be uncomfortable. It has to be. And otherwise we don't get anything changed. So we will be, this is obviously recorded, it will be sent out via Futures. So you will get, and I've been collecting resources in the background that Lynn's been sharing, so they'll come out. And we'll be sending out the links to the information that's on our website as far as the expert witnesses are concerned. And then if we come on, so the next dates for next year will be the 4th of March. I think sorry, I'm jumping around. The 4th of March, there's one in June, there's one in September, there's one in December. There you go. So we will be sending those out in preparation for next year. Our closing thoughts will be, there's an importance of citizens' jury in a citizen's voice in healthcare. There's a need for sustained engagement and implementation. And there's a link there to our website that's got all the information on there. It's been a pleasure working with you all. I'll be in the background from here on mute, camera off, and but celebrating and applauding you as you go. Please keep carrying on this amazing work. I know you all do really, really hard work in the background. And can I just say it's been an absolute pleasure working with you all. So I'll be handing the reins over to Cormac and Dennis, and thank you very much for your time. And bang on, look at that. Thank you very much. You can all head off now. Thank you.